Good afternoon, friends. Good evening, rather. So, welcome to the 102nd webinar of our series. And I am proud to be presenting today. One important news for people who are attending, being centenary celebration, this webinar will also be on YouTube permanently, free for you to see. So don't bother taking pictures and all, you can go and see anytime. So the topic that I have selected is in keeping in mind the right prescription. We discussed with Dr. Suhas Prabhu and Dr. Rajiv Soman, right prescription of antibiotics in diseases. Now I'm going to talk to you about right prescription, writing a rational prescription. In one line, if I have to say no, tomorrow or a year later, anybody questions you, how did you write this drug to this patient? You should be able to answer without worrying. So let's begin our journey. Once again, this webinar will be available on YouTube, open domain, free for you to see forever. Rational prescription. Today I am using not only my medical skills, I am using my medico-legal skills because I have done a diploma in medico-legal systems. So I would like to apprise you of what is expected of us while writing a prescription. What is a prescription? It's a written document that details treatment advice by us to a patient. Even if you send it on WhatsApp, it's a written document. Ideally,
that's beyond my abilities for now.
Ideally, you should never send name of medicine on WhatsApp. You should always keep certain prescription papers in the clinic, in the house, in the car, so that you can write down on that and send a snapshot to the patient. It is a medico-legal document. Even if you print not for medico-legal purpose. A lot of doctors, more in the north, print on their letterhead not for medico-legal purpose. I would like to tell them in a very rude language कि ये मेरे पिताजी का country नहीं है कि I can say not for medico-legal purposes. The very fact I am a registered doctor, registered to practice in this country, I have to abide by all the laws of the nation. I cannot say I will decide it's not for medico-legal purpose. So please make sure that it is a medico-legal document and you can be questioned on that. When I said the word that details treatment advice, this term only should tell us that writing a prescription is a task where multiple aspects have to be remembered and complied. You have to remember, you have to comply. I was shocked to see in my clinic, one patient brought my prescription paper. My assistant doctor had given that prescription without patient's name, date, and signature. It's criminal. So prescription has two components. One is medico-legal and one is rational. Like now, one of the laws that we are complying with is of biomedical waste. Similarly, every prescription has certain medico-legal component and certain aspects of making a rational prescription. Writing a rational prescription is a thought process. Enough jokes have come about our handwriting. Even Alka ma'am also tells me, she shows me prescription of very senior physicians writing tablets Septran half BD or half OD as a preventive for HIV patient to not to get pneumocystis carinii pneumonia. So what I'm saying is, we all make mistakes. So rational prescription is one, medico-legal is one. Let's cover the medico-legal part. From National Medical Council, what code of ethic regulation pertain to a prescription? Clause 1.4, display of registration numbers. Your prescription should carry registration number and the medical council from where the number has been obtained. 1.4.1, every physician shall display the registration number accorded to him or her by the State Medical Council of India in all his prescriptions, certificates, money receipts given to his patients. You cannot say, if I print, then it is likely to be misused. No, it has to be there. Few doctors have been arrested because the chemist complained that there are such errors that this person cannot be a doctor. He complained to the FDA. When it was checked, they were unqualified people practicing without registration. 1.4.2, physician shall display as suffix to their names only recognized medical degrees or such certificates, diplomas, and membership honors which confer professional knowledge or recognizes any exemplary qualification achievement. I yesterday saw a prescription which in the degree had PEP. I searched Google, I couldn't find. So membership of societies of hygiene in UK is not something that confers professional knowledge. And if somebody wants to take action against you, they can take action. Then the law expects us to write generic names of drugs. Every physician should, as far as possible, prescribe drugs with generic names, and she shall ensure that there is a rational prescription and use of drugs. So this sentence, part of the sentence, as far as possible, gives us protection to write brand names. But if you see today, all the prescriptions which are generated by computer systems, in the bracket give generic names also. One thing you can print on your document, prescription document, substitution not allowed. Even brand substitution not allowed, because you are given a prescription, it is your medical legal responsibility that the patient gets better. We have seen incidences where you have given a particular NSAID and chemist substitutes with another NSAID saying dono painkiller hai. Not done. So you have a right to write brand substitution not allowed. Sorry, this is the same thing coming up again. Prescription should also make clear if the physician himself dispensed any medicine. So if you're writing outside medicine, you can write that what medicine you are given from your clinic. A physician shall write his name and designation in full along with registration particulars in his prescription letterhead. Then there were some questions on our Telegram group. Can we sell medicine? Running an open shop, dispensing of drugs and appliances by physician. A physician should not run an open shop for sale of medicine for dispensing prescriptions prescribed by doctors other than himself. Understand? So a prescription of somebody, you cannot give medicine to that person or medical or surgical appliances. It's not unethical for a physician to prescribe or supply drugs, remedies or appliances as long as there is no exploitation of the patient. This indirectly means you cannot charge more than MRP. Oh, why are these things coming up again and again? So overcharging and selling samples is prohibited. What is professional misconduct? What happens if you don't follow these rules? The following acts of commission or omission on the part of a physician shall constitute professional misconduct, rendering him her liable for disciplinary action. 7.3. If he/she does not display the registration number accorded to him/her by the State Medical Council or Medical Council of India in his clinic, prescriptions and certificates issued by him or violate the provisions of 1.4.2, which I read earlier, then this person can be suspended for some period of time. Rational prescription, as I told you, you may be questioned by another doctor. Another doctor can tell a patient, oh, I am surprised, ye sab kaisa likh diya, how he wrote all this. You should be able to justify your action. Prescription writing has to be properly addressed with regard to its correctness and appropriateness. It should be correct, it should be appropriate. Any errors in the prescription writing have to be identified and eliminated. So today, you see what I'm talking. If anything of this you are not doing, please start doing, or if you're doing incorrectly, then correct that. Electronic prescribing has abolished most of the typographical errors, but the rationality involved in prescription is a thought process of the prescriber or us. We have to think. You cannot give a prescription in a hurry. Irrationality in prescription leads to medication errors, causing increased morbidity or hospitalization and an economic loss. If your patient stays close to you, you can tell them, come and show me medicine. But if you are a doctor whose patients come from far and wide, they may go and buy nearer to their house. So you can't say, show me. You have to write clearly. I have started one thing. I know even my writing after 45 years of practice has gone bad. So I write all the brand names in capitals. You can't make mistakes that the chemist can't read in capitals. And why economic loss? Today you are given a prescription without thinking. Patient has spent 400 rupees for that strip and day after tomorrow you change it. That's a loss to the patient. Define your therapeutic objective. The most important part of prescription writing is, what do I want to achieve by writing this prescription? Choose the right medicine specific to the patient's needs, and I will also say pockets. Because if the patient trusts you, he will buy the medicine. He may not give milk to the child for a day to afford that expensive brand that you written when other brands of better quality or good quality were available. Compliance and outcome of therapy. Patient should follow the prescription to the T and get better. That is what we want the patient to follow our prescription and get better. This, in addition to a prescription, requires doctor-patient communication and proper information. I'm going to narrate a case later today, which will tell you what is the communication level you should have. Relationship, doctor-patient relationship means the patient has to trust you and you should have empathy towards the patient. Our commitment and empathy towards the patient. Morbidity occurring because of irrational and inappropriate prescription can be curbed with education and awareness of the prescriber, that is us. So the first step into writing a rational prescription is clinical acumen. You should have good, sound medical knowledge of the disease that you are treating. Rational prescription writing. Prescriber's details, our name, address, registration number with name of medical council and contact number of the treating doctor. You will say, why should I give contact number? The registration number of the doctor is an assurance for the patient that we are registered with a medical council. This reflects the authenticity of the doctor. The number, why it is required? To contact the doctor in case of emergency or adverse drug reaction. Now, one thing I will tell you, I don't know how. Every patient who comes in the clinic somehow gets your mobile number. So if you are giving a drug to somebody which you feel can have adverse reaction, if you are giving some medicine to somebody and you feel that this medicine is not likely to work, even if you're not printed your number on your stationery, there should be one number at least. Then at the back of the prescription, you write with hand your personal number and write below that only in emergency. Superscription. What is called superscription is this RX that we write. It represents a prescription order. In Latin, it means it's a recipe, or take thou, that is, you take this. So I write the name of the patient, gender, age. I write everything. I don't write Ashok only. I write Ashok Mehta, 64 male. Then I write RX and then I start prescription. Inscription is the main body of the prescription. It contains the names and quantities of prescribed medicine. Very important. Physicians are supposed to write the generic name of the drug prescribed. You may write brand, you may write generic. If you're writing a brand which you feel may not be available, then you write two brands. You may write generic, but tell the patient that you have to take one of these two brands, or show me which brand the chemist is giving. So you have a right to reject the brand if you've not heard of that pharma company. You may say, why get involved so much? It's your commitment to the patient. Its dose, its frequency, and the duration of therapy all have to be written. Nothing verbal. I can't write 101 and tell the patient verbally, eat before meals. No, I have to write there before meals. This part of the prescription is most important area where the physician has to be very careful and vigilant. Our knowledge about the medicines and our competence is reflected by what we know and what we write. Like today, it's become a fashion. Even when NSAIDs are not given, people write proton pump inhibitors. They write twice a day. Why? I don't know. Treatment of diabetes, hypertension, they write proton pump inhibitors. Why? We don't know. But nobody's to question the doctors. The direction to be given to the patient regarding the administration of the drug should be written down. It usually indicates the quantity of the medicine. If it is 1 capsule, 2 capsule, 5 ml, 10 ml, 7.5 ml. The number of dosage units to be taken once, twice, thrice, 4 times. Imagine when we were giving acyclovir, before famciclovir came on, we were giving it for herpes patient 5 times a day. We had to explain to the patient, come what may, you have to take 5 times a day. The number of times in a day the medication has to be consumed. The relationship of its timing of intake to the meals taken. I may write twice a day. And I know logically twice a day should mean 12 hours. So I tell the patient minimum gap 12 hours and I draw a two-sided arrow in between that 1-1 and I write 12 hours. If I'm giving a beta stimulant to a child for wheezing and I just write 3 times a day, patient has come to me early morning, 10 o'clock. Patient goes home, 10:30, first dose. Second dose, 2 o'clock. 5 o'clock, you get a call, child is trembling. So then I write minimum time 7 to 8 hours between 2 doses. So these are the instructions which make your prescription rational. The way it is to be administered or applied. Simple things. I give somebody antifungal powder and I just say twice a day. Am I making a mistake? I'm not making a mistake. What people will do, because it's in the folds, they take the can and they sprinkle it there. All the folds people sweat, they sprinkle it, the powder gets caked. What was dry intertrigo becomes wet intertrigo. So I will explain to the patient, I may not write all this. Take some powder on your hand and apply to the area, a thin film. I have to say that. Patient always thinks patient has got itching, you give an ointment and patient feels if they apply more, it will get better sooner. But a thicker film of the ointment stops the skin from breathing and is less productive than a thin film. So you have to tell patient, I still write, apply very small quantity, use frugally if the patient is educated. Should also include specific advice related to diet. Empty stomach, before meals, after meals, soon after meals, or things like woglibos and all, we tell people after the first morsel. So all that has to be written. What lifestyle modifications? If I'm treating ankle sprain, I will say rest, no weight bearing. I will write down. I have been always saying that our prescription of diet and exercise should be written down and charged. So I will write down rest. If a patient has got viral fever, and I know the patient goes to the gym, I will say gym at 50% of usual, if can. I will write hydration, I will write 2.5 liters of water. Other non-pharmacological measures, if you are giving steam, I myself tell people no Vicks, plain steam. You want to say Vicks, you want to put Carval, you write that. Follow-up instructions. There are certain medicines which we tell people have to take long time, but we want to see them in 10-20 days to decide whether they should continue for long. Like Montelukast. If I'm giving somebody for severe sinusitis with hypertrophic turbinates, I may have to give longer. So I will give a prescription. I'll write 20 days plus plus. I will tell the patient, if you can't see me in 20 days, you take till you see me. In certain drugs, I will write, like if I am giving calcium to a menopausal woman, I will write always. So I have to give those instructions and I have to tell patient, see me on this date. And if you're giving a date 15-20 days ahead, please remember, are you going to be in office that day or no? Date. The inscription of the date on the prescription is not only important for patient, but for doctor also, and the pharmacist also. With regard to the patient, why the date helps the patient? Ascertain the course of therapy. People are busy, they forget whenever they come to you. But if you have a prescription which is dated, then they know which day they have come to you. The timing of follow-up required. It also serves the purpose of aiding as medico-legal evidence in the court of law. From the doctor's viewpoint, it indicates that patient is complied to treatment. Helps with determining the validity of the prescription. I write on certain prescriptions to be supplied once only, so that the prescription is not abused, especially in antibiotic prescriptions. In avoiding unnecessary redispensing of medication described in the prescription. Redispensing using the same prescription is harm to the patient and economic loss to us. You know, about 2 years back, government came up with a law for psychotropic drugs that alprazolam, etc., cannot be bought without a fresh prescription. One gentleman came to my clinic with a prescription which was torn, stuck with tapes. He came before COVID, 2018, November, December, and he told my staff, nowadays chemist is not giving me, tell doctor to give me a new one. The prescription was dated 2008. 10 years he had been using that sedative. He was harming himself and I was losing my income. The pharmacist cannot identify an old prescription brought for redispensing if it is not dated. How to ensure there is no repurchase? You can start writing down. Either you print, we are thinking when our next lot is printed, we will print there, no substitution and supply only once. Last but not the least, prescription should be signed and dated. The onus lies on us for being responsible for the facts mentioned in the prescription. So before you put your signature, make sure that you're thought of everything that has to be thought about writing the prescription. To safeguard our interest, we should be well acquainted with the art of writing a prescription. There is no margin of error. As while treating patients, we have no margin of error. A prescription directly deals with patient's life. Sorry, I made a mistake today. I will be careful next time. No, we don't have a time. We don't have a second chance. So let's see 9 steps to writing a prescription. When you sit to write a prescription, ask yourself, is the patient's problem defined? If the patient came with a vague history of uneasiness and tired, have you defined the problem before you start writing? Have you arrived at a specific diagnosis? Definitive diagnosis or presumptive diagnosis? Have you decided that this looks like dengue? Let me wait till tomorrow, then I'll do a test, because the fever duration is only 2 days or 1 day. Have you decided that it could be enteric, but I'll wait for a day or two to see the improvement, then I will order tests based on the clinical examination finding? So have you arrived at a diagnosis, presumptive or definitive? Have you given a thought to pathophysiology of the diagnosis? I always say that we have to think what is causing this problem. And I'll tell you, a doctor who thinks of pathophysiology is always going to be successful. Everybody has seen, दया पता लगाओ ये क्या हो रहा है. That means in the patient's body, what is happening that is giving him this symptom. Is there a good understanding of the disease process? If yes, we are in a much better position to prescribe effective medication. The patient relative should be provided with appropriate level and amount of information about the pathophysiology based on their education level and your comfort in describing a complex medical term. It has been observed that the compliance with the prescribed therapy improves if the patient understands the implication of the disease. So if I'm treating an amoebic colitis, patient has eaten sev puri, pani puri from outside, and has got severe tenesmus, blood and mucus. I have to tell the patient that 40 feet of your intestines are affected. And with the medicine, I have to clean the 40 feet. So next 5 to 6 days, you may pass more stools than you are eating, but that is cleaning up your gut. And you need that 5 days. If you feel better in 3 days, don't stop medicine. If the patient comes to you, our patients are very worried of swelling. A girl came to me with a huge boil on the middle of the leg, which was absolutely red. But she was more concerned about the swelling below. So we have to explain that inflammation has swelling, and because of gravity, the swelling is coming down. The swelling will not disappear till this boil heals completely. Have you defined the therapeutic objective? What am I going to achieve by giving a prescription to this patient? A therapeutic objective for each of the pathophysiological process identified. If I have identified 2 different processes, then that is my objective to treat. If I have a patient of reflux and I have a patient of spastic colon, then I need a prescription for both of them. I need therapeutic objective for both of them. In a patient with ankle ligament sprain, achieving a relief of pain caused by inflammation, sorry for the spelling error of pain, caused by inflammation, rest to part are the major therapeutic goals that identify the group of drugs that should be considered appropriate for the patient. I have to reduce inflammation. I have to give the patient rest. Ensuring adequate rest, letting ligament regain original position is important. And you have to explain to the patient that ligament is stretched. If it doesn't regain its position, you'll have an unstable ankle. So although there is no fracture, you must rest for 15-20 days. Have you evaluated patients' comorbidities? Every prescription should keep in mind patients' comorbidities. So if you have a patient, your own patient, who's under treatment for diabetes, hypertension, I hope you are giving files to patients, or if you're not, tell them that whenever they come for any symptom, they should bring what drugs are going on. Diabetic with CKD, UTI, patient gets UTI, is a diabetic, has chronic kidney disease, creatinine is 3.4. You do a culture. Its only sensitive antibiotic is nitrofurantoin and cotrimoxazole. You should know nitrofurantoin is now contraindicated in most patients with an estimated GFR, eGFR of less than 45 ml per minute. So you have to see, patient will not remember. Patient will remember, may remember creatinine, but will not remember eGFR. And this also tells you, when you check creatinine, you should do in a lab which is giving you estimated GFR. Then cotrimoxazole, dose adjustment for renal impairment, creatinine clearance 30 to 50, normal, 15 to 30. In pneumocystis carinii pneumonia, normal dose for 3 days, then 50% of normal dose, and other infections, 50% of normal dose. Less than 15%, 50% of normal dose at normal frequency. Now I must give you an example. My younger brother with a creatinine of 3.1 has fever with UTI, admitted. Culture came positive, and the intensivist, very knowledgeable, gave cotrimoxazole for 3 weeks. 1 week later, creatinine 3.6. He said, don't worry, it's not that big an increase. Second week, creatinine 4.1. Then nephrologist said, ma'am, she is getting into acute on chronic renal failure. So all I'm saying is that you should always, if you don't have a computer, at least have a good phone where you can search risk profile of drugs. Have you identified a drug of choice based on efficacy, safety, suitability, and cost? I have a simple formula for cost. Can I afford this medicine? If yes, can the patient afford this medicine? You should know patient's pocket, and don't feel bad in asking the patient that this drug is slightly expensive. A 5-day course may cost you 700 rupees. Are you okay to take that? I had a child with collisis fracture. The patient was educated, well dressed. I asked him that if I send you to a private orthopedic surgeon, it may cost you around 8 to 10,000 full treatment. You are okay to spend that, or you would rather go to a municipal hospital? He said, good, you told me, I'll go to municipal hospital. So cost is very important. Every pharma company, new one that comes to you, is definitely making more expensive products. And on our Telegram group, if you have been active, There have been discussions of labs, which products are very effective and very cost effective also. Drug of choice. A single drug or multiple group of drugs may be indicated for each therapeutic objective. Selection of a drug of choice from these requires consideration of characteristic of the patient, clinical presentation, and characteristic of the drug. Last two lectures, I have tried to give all of us little intelligence of thinking of the type of bacteria that may be causing infection before writing antibiotic. For several drugs, characteristics such as age, comorbidities, and concomitant medication, very important, what other medication patient is taking, are extremely important in deciding the most suitable drug. We all know a patient on AKT, oral contraceptives are not likely to work. Selection of drug is based on four important criteria, which I mentioned: efficacy, safety, suitability, and cost. Efficacy is the decisive factor for choosing the drug. You do not have the right or liberty to think, देख लेते हैं, जो ही लइए, let us try this. No. Suitability refers to the selection of appropriate dosage and formulation while keeping the patient's characteristic, clinical state, and presence of any contraindications of the medication being considered. Weight is very important. All of you have seen patients of 70-80 kilos being given rifampicin 450 milligram. Write the drug with appropriate dosing regimen. Dosing and duration of therapy is disease specific and is determined by the pharmacokinetic, absorption, metabolism, and excretion of the drug. We need not be a pharmacologist. Most drugs get metabolized in the liver. Extremely important to assess the hepatorenal status of the patient. I need most drugs metabolized in liver, most drugs excreted in the kidney. So I have to keep a mind of hepatorenal function. If it's a new person, are you a diabetic? Yes. Is your creatinine normal? Yes. When was it done? 1 year back. Okay, then repeat it. That day you can take a chance. The clearance of drug from plasma is slow in patients with compromised hepatorenal status, leading to toxicity, and we should be watchful while prescribing medication to pregnant and lactating women. Whether the drug is excreted in milk, then even giving a strong NSAID to a mother is not advisable. Then biggest thing which causes lot of morbidity, not only in India, even in US, drug-drug interaction. Which drug reduces the effect of other drugs or enhances? So where dose adjustment is required. Our company IDG is working on an app which will give all the pharmacological tips to the doctor. It will be mobile app. Maybe in 3-4 months it should be out. Write the drug with appropriate dosing regimen. Start the treatment and give information, instruction, and related possible caution warning. You have to ask everything about the disease. I'll give you this case. See, I'm not trying to show that I am better than others, but what I'm trying to say that as a family doctor, we have to be better than consultants. This patient came to me, new patient of mine, and he brought a file of a dermatologist. He's been under treatment for 3.5 months. So much so that even a skin biopsy of the lesion was done. And the biopsy had given a very simple diagnosis of contact dermatitis. Now, he was on every possible drug that could have been given to him. I had nothing to give him. He was on Atrax 25 milligram at night, 10 in the morning. He was on Allegra 180 at lunch. He was on desloratadine. What else I could give him? He had been given a course of steroids. Something in the patient's appearance made me ask the question, sir, how often you change your clothes? Once in 4-5 days. Have you been bathing every day? No, I bathe once a week. I'm very weak. I said, see, if you have a skin problem, you need to keep the skin clean. You buy a plastic chair, sit on the chair and take bath. What about your bed sheet? I wash once in 2 weeks. And I said, what about mattress? Yes, doctor, my mattress is old. I have been thinking that maybe my skin disease is because of my mattress. I told him that take bath every day, maybe twice a day, and take a new sheet. New sheet means no, don't buy new, something unused from your house. And one day you sleep on the floor. And next morning he called me saying he's 50% better. He came 1 week later, he was 80% better. And now we are going to gradually reduce his medication. So you have to give instructions and related possible caution and warning because you understand the pathophysiology. How can contact dermatitis occur all over the body? We have seen contact dermatitis where bindi is applied, where rings are put, where watches are put, where bangles are put. We have seen contact dermatitis on penis due to condoms. You can't have contact dermatitis all over the body, so there is something else. Monitor the therapy and suggest follow-up. Write down when the patient should see you. If you want a test to be done, if I'm treating a urinary infection with a pus cell of 150, 200 today, and I'm giving a 10-day nitrofurantoin, I have to write, check urine on 9th day, in case you have to continue. We should be able to explain to the patient the kinds of adverse effects that need to be monitored. The patient should also be informed regarding the laboratory tests necessary at appropriate times and what signs and symptoms of the disease or the medication administered should be reported. So, if I'm giving somebody methotrexate for rheumatoid arthritis or psoriasis, then I have to say once a month, CBC, SGPT, creatinine, and routine urine should be done and brought to me. If I'm treating a patient of chronic kidney disease, I want every month CBC, creatinine, and potassium. So all that is a part of writing a prescription. For illnesses that require a short course of therapy, like most infections, the duration of treatment should be explained. Many patients have stopped the medicine because the bottle got over. Symptomatic improvement had occurred. These patients are going to bounce back with reinfection. So as a good doctor, you have to think if you're giving a medicine which is 30 ml and you said 5 days, you have to tell the patient upfront that you will require 2 bottles and 10 ml may go waste. That is your job. And do not stop even if better. For a patient with a prolonged illness like bronchial asthma, COPD, type 2 diabetes mellitus, the need for a prolonged therapy should be explained. Why they should not stop inhalers. You have to explain to them, inhaler is better than oral medication. One tablet is equivalent to the drug going in 1 month of inhalers. And why certain inhalers cannot be taken only once a day. We should also specify to the relatives of the patient to look for any changes in the patient's condition that might require a change in therapy. A patient of cirrhosis of liver, I have to caution the patient, make sure there is a bowel movement every day, there is no constipation and any altered sensorium report. If I'm sending back a query head injury, I have to tell them to keep asking the child silly questions so that you know the child is in normal senses or there is altered sensoria. Major toxic reaction that require immediate attention should be explained to the patient. Like a discharge summary of a hospital. A discharge summary tells the patient, report back in case of fever, vomiting, backache, altered sensorium based on the condition that was treated. You have to also tell the patient's relative that report immediately. This is my personal number. Now, I am giving some information about H1N1. I thank Dr. Vishnu Mulchandani who shared this BMC directive with us on our Telegram group. Thanks, Dr. Mulchandani. There are 3 categories of H1N1. Category A, mild fever below 38 degrees centigrade, cough, throat irritation, body ache, headache, diarrhea, and vomiting. No swab collection recommended. Understand, the swab collection RT-PCR for H1N1 is almost 4,500 to 5,000 rupees. Treatment is home isolation, no oseltamivir, symptomatic treatment, review after 24 hours. In addition to above symptoms, fever above 38 degrees centigrade, severe sore throat, and badly running nose. Swab of selected patients belonging to high-risk group. Again, we're not saying swab of everybody. I'll tell you which are the high-risk groups. Home isolation, oseltamivir if needed, use antibiotics if needed, secondary infection. In addition to above, category C, breathlessness, chest pain, hemoptysis, hypotension, bluish discoloration of nails, and in children, irritation and drowsiness, altered sensorium. Swab of all patients, oseltamivir and hospitalization. And for H1N1, you don't have jumbo hospital facilities, you don't have government paying for it. There are very few hospitals, even in Bombay, where these patients are admitted. So better to prevent. High-risk groups are pregnant women, children less than 5 years, elderly people more than 65 years, people with comorbid conditions, hypertension, diabetes, respiratory disorders, all the risk factors of COVID, immunocompromised patients, and patients on chemotherapy. Lastly, I would like to make I'm just sharing management of H1N1, which I have taken from Medscape. H1N1 influenza A, swine flu prophylaxis, 75 milligram orally once a day. Post-exposure prophylaxis, you met somebody who later on diagnosed to be this, and you have a cold and all. Initiate within 7 days of exposure and continue for at least 10 days. Pre-exposure prophylaxis, community outbreak. In your office, 3 people diagnosed with H1N1 and you are not feeling well. I will call it pre-exposure prophylaxis. Initiate during potential exposure period and continue for 10 days after last known exposure. Consider longer duration, more than 5 days in severely ill patients who remain severely ill after 5 days of therapy. Treatment, 75 milligram of oseltamivir orally twice a day for 5 days. Initiate within 48 hours of influenza symptom onset. Many a times you need not even do swab test, RT-PCR. Renal failure, Creatine clearance 60 to 90, no dosage adjustment necessary. 30 to 60, you give 35, not 75. 10 to 30, you give once a day. ESRD, not undergoing dialysis, we will not give because not studied the effect. And creatine clearance less than 10, patient on hemodialysis, 30 milligram orally immediately, and then 30 milligram after every hemodialysis cycle. Treatment duration not to exceed 5 days. Less than 10 ml creatine clearance, patient on peritoneal dialysis, single dose of 30 milligram administered immediately, one dose only. And lastly, Dr. Dheeraj Mulchandani, son of our beloved Vishnu Mulchandani, has received a personalized letter from our Honorable Prime Minister Narendra Modi, thanking him for his active participation in the COVID vaccine program. Congratulations, Dr. Mulchandani. And that is all for today. So we have some questions. Some patients do use same prescription repeatedly. So I just told you, write it down. Please dispense only once. Can we write on stamp only as consultant physician with registration number without credentials? No. No, you cannot. Credentials have to be given. A prescription, patient gets relief. He preserves that prescription. Another member of family, friend, neighbor gets similar symptoms. Patient uses the same prescription. The user shows signs of adverse reaction. How to discourage such practice? So when you are giving a prescription, you have to tell the patient, see, this is for now. It does not mean next time you have a sore throat or burning micturition, you take this medicine. And if it is given to other people, they may get reaction and we are not responsible. That's why I said that we have to talk more and write less. Cost point always ignored. Thanks for bringing this to notice. Yes, it hampers the monthly income economic balance. See, for 45 years, I do not prescribe tonics. Because early on in my practice, maybe first year, I wrote a tonic to someone. And then a month after that, they brought a child. And then I asked, do you give him milk? No, sir, we used to give him, but when you give that medicine, we don't afford all that. So then we stopped giving milk. So when it is required, yes, only for a limited time. Our Telegram link group, Preeti, there is a group name is Inches Academy IDG. Contact dermatitis. Thank you, Dr. Kamath. Many patients do not understand English, whereas most of our prescriptions, including hospital discharge cards, are written in English. Also, a doctor may not always know to write in patient's language. See, Dr. Aarti, you brought a valid point, and my duty is to answer everything. So I have a patient who I can myself write Marathi, I cannot write Gujarati. So this patient is Gujarati and she says, I can't understand what you write. So I told her, now you sit here. I gave her a pen. I told her to write in Gujarati what I am telling her. I will do the same thing to somebody who speaks Malayalam, Kannada. Time is, you have to give time. You have to give time to every prescription. How to address this question 2? Effect on treatment of outcome as patient fails to follow instruction even if explained verbally. That is why I said you record. You record on paper, you write it down. Medical legal implication of giving legal document to patient or cannot understand. See, it's like a consent in the hospital. So many hospitals, when the patient is really critical, they will make the patient write in their own handwriting and language. I have been told that son has got liver tear and we are going to remove the liver, which will affect him in future, then you have to write. So we are not taking consent in our practice. But this medico-legal document, if you're giving, like all the systems generated today are giving instruction in vernacular also. But I suggest you start writing. And if you have a good practice, then what I will suggest is, see, I am not a practitioner with large numbers. Otherwise, I would suggest that you start writing, get the documents printed. I'll just show one thing. Second thing, I would say that never use prescription of a chemist. From day one of my practice, this is my small prescription. And this is my temperature chart, where in the bottom in the English, it is written the diet instructions. So if people don't understand, we write them. I write 2 to 2.5 liters of water, pani, 2.5 liter, 2 fruits. We write all that. And Dr. Aarti, if we are giving a prescription, we have to give it, then we have to be very careful what is being done. Plenty of water with aspirin, doxycycline, yes. Plenty of water per se. Like, most of the patients who come to you with fever, first thing is hydration. I used to take 2.5 liters, but now I have bitter mouth. That is the reason we are telling you. What about patient repeatedly for alprazolam for years, but reluctant to pay? Should it be charged? Yes. See, some things we have to change. Now, my son is joining swimming pool. Give a certificate. Patient will never ask you how much they'll pay. But if I print that on a letterhead, then they have to ask how much to pay and we will charge the fee. Dr. Mulchandani, you are getting a lot of congratulations. Since most of the now are presenting with cold throat irritation fever, how do we differentiate from H1N1? See, H1N1, even when I showed that image, and those who are on Telegram group, that document was put by Dr. Mulchandani this morning. Category B also has severe running nose. You will see water dripping. Most of the things that we are getting now are not having that much running nose. So you can take a call. Cost, very important aspect. If prescribed of personal gain amounts to cheating. Yes. Dr. Rohit, you have given me motivation to add this point. Lot of pharma companies come to you, write this cough syrup. For every bottle, I'll pay you 50 rupees. Tell them not to enter your clinic. Because one thing I have learned, it's not medical knowledge. Everything that we earn fraudulently now goes away somewhere wrongly only. No cough syrup should be allowed to be purchased as per chemist's advice, because they have schemes 10 pay 10 free and they will keep selling those to patients. H1N1 vaccination is same as influenza vaccine. So see where we fail. In 2016, when H1N1 epidemic came, I started telling patients, that time vaccine was 1200. I said, if I suspect H1N1 in one member of the family, the test is 4,500. And for 4,800, 4 of you can take a vaccine. But they thought we are making money. So if you are motivating people to take vaccine for influenza, then H1N1 is covered. webinar subscription and masterclass subscription will be together or different? See, webinar, we are coming out soon. We are just working out the logistic, how we will give 1,000 rupees per year. You can see all webinars any number of times you want. Masterclass, of course, are different. So that will be different only. Recording of today's session from tomorrow will be on YouTube. Please comment upon you give to your patient 10 mg in morning and 20 mg. If 20 mg plus 20. I didn't get you, Dr. Ashok Madan. Please, can you clarify? Can we prescribe multivitamin based on symptoms with blood checks? Yes. See, if there's a deficiency, you give. Somebody says, no, I'm feeling tired. Don't write 4 tonics. Today, if you see prescription of every dermatologist, it is filled with 6 multivitamin combinations. Dr. Ashok Madan, please write what are you talking? I didn't get you. What I understand is, if I'm giving, like, suppose I'm giving ranitidine 150 in the morning and 300 in the night, then I write both the drugs and write that way. Dr. Suresh Khilari, my classmate who was retired from practice. Suresh, how is America? He is in America, he is attending. Keeping a copy of prescription. Yes, very valid point. All the certificates, you have to keep a copy, but it's better if you start keeping a prescription copy also. Dr. Shraddha is saying she is taking a picture of prescription in mobile for record. Very good. So I think this is something which we learned today. Whatever prescriptions I gave in COVID for online, I have all the images with me. But you can do this. This is a very good suggestion. I thank you, Dr. Khilari and Dr. Shraddha. Please keep a copy of every prescription because no point in keeping carbon behind. So I think all the question answers are over. Next week, you will be fortunate to hear Padma Shri Alka Deshpande talking on prescription in antibiotics in high-risk patients. Thank you very much. Have a nice evening.